Professor Pinsky, and thanks to the organisers for inviting me to speak on this topic. It's a great pleasure. I have no conflicts of interest, and I'll talk through RV-PA coupling in the critically ill patient. So just to show some echo images of right ventricular injury, and we can see from these images that it's a real spectrum of injury in the critically ill. We can see here this patient has RV dilatation but has got relatively normal systolic function. This patient has acute on chronic cor pulmonale. This patient has acute cor pulmonale. And these are all sort of a bit of pattern recognition. You can see there's dilatation. We've got this thing called McConnell's sign here. This patient had a pulmonary embolus. And here we have a patient that's had a right ventricular infarct with regional wall changes and significantly reduced systolic function. So we can see that this RV injury is very heterogeneous in our group. But one thing that these patients all do have in common is as they progress from this right ventricular injury towards right ventricular failure, at some point along this pathway, they will uncouple from the pulmonary circulation. So what is RV-PA uncoupling? Well, from a very simplistic sort of conceptual perspective, we can think about the coupled right ventricle as one that's able to match its function against an increased afterload. And this is a happy right ventricle. We can think about the uncoupled right ventricle in being a ventricle that cannot adapt to this increased RV afterload and starts to run into a lot of trouble. But of course we can't, we know that the right ventricle is inextricably linked to the pulmonary circulation, and this is beautifully outlined by Garancino and Professor Pinsky in a very nice article in 2017. Which I'd recommend reading. But just to go back to some basic physiological principles, of course we can't just think about it as in those cartoon sort of conceptual ways. So let's take the RV pressure volume loop, and this is for illustration purposes. Of course we know that the RV pressure volume loop is usually more triangular in shape because of the indeterminate isovolumic periods, because it's ejecting into such a low impedance circulation. But we usually read pressure volume loops, of course, from right to left. We'll start here at the end diastolic point, where the tricuspid valve is just closed, and we have isovolumetric contraction, and the pulmonary valve opens, and then we eject rapidly into the pulmonary circulation, and the pulmonary valve closes again. And then as we get isovolumetric relaxation, the tricuspid valve opens again, and the right ventricle fills. So elastance is, of course, a change in pressure for a change in volume. And the slope of the end systolic pressure volume line is known as the RV end systolic elastance. And this is, for all intents and purposes, a load-independent measure of RV contractility. If we connect a line from the end systolic point to the end diastolic point, then the slope of this line is the effective arterial elastance, which is a metric of RV afterload, which takes into account both the pulsatile and the non-pulsatile components of the pulmonary circulation. And the ratio of these two metrics, the ventricular elastance over the effective arterial elastance, gives us this metric of RV-PA coupling. So the right ventricle is I like to think about it as being in health. It's a sort of pretty chilled out ventricle. It has a lot of mechanical energy to spare. And in health, we have this, the ES to EA ratio is around 1.5 to 2, and there's very efficient transfer of that potential energy from the right ventricle into the pulmonary circulation. But as we subject patients to increased RV afterload, for whatever reason that may be, the RV has to compensate for that. And it does it in a couple of ways. It has this heterometric adaptation, or the ANREP effect, where it can increase contractility without necessarily increasing its volume. And then a little later, it uses the Starling mechanism to recruit more stroke volume and dilates to maintain that coupling. And we see patients with chronic pulmonary hypertension with dilated, thickened right ventricles, and they're walking around, or they're at rest, when they're at rest and they're not excessively exercising, they're usually doing okay. It's not until something goes wrong that they fall off their perch. But what happens with progressive RV injury and an RV failure is that these Frank-Starling mechanisms are really exhausted. and we get extreme dilatation, and we get that negative systolic and diastolic interaction with the left side. We get RV coronary ischemia, and then the stroke volume starts to decrease. And we start to see this drop off in RV contractility. And below coupling ratios of around 1, that's when we start to see the signs of RV failure with increased central venous pressure, etc. So the ways that we can measure RV-PA coupling, the gold standard is using a multi-beat method, where we use a conductance catheter to measure simultaneous pressures and volumes. And then we can reduce the volume to make a family of curves using IVC occlusion balloons or the Valsalva maneuver. And you can see in this patient here, we have the conductance catheter and an IVC balloon. So what this does is enables a series of curves or a family of curves, and then it's the slope of this of these end systolic points which make the end systolic pressure volume relationship and the effective arterial elastance line, and we can calculate RV-PA coupling. And this multi-beat method has been shown to have prognostic significance. It's relatively small studies. There are 26 patients in the study by Stephen Chu, with a cutoff value of less than 0.65 for this multi-beat ES to EA ratio predicting clinical worsening. And in a study by Richter et al., 38 patients, again, similar cutoff values, 0.6 to 0.7, showing that these metrics really do have prognostic significance in patients with pulmonary hypertension. But of course, these multi-beat techniques are quite difficult, and to bridge that gap between bench and bedside, we need simpler techniques. And using PA catheters rather than RV conductance catheters, and using MRIs to derive volumes have been looked at over the last decade or so. And this is a busy slide that I apologize for, but I'm going to try and reinvigorate my trigonometry knowledge to explain this. So essentially, we can use a single beat method where we don't need to have the IVC occlusion balloon in, and we can generate that. We can use the pressure method. Okay, so with this method, what we do is estimate a maximal pressure, and then the line that connects this maximal pressure to the end systolic point, the slope of this line is the end systolic elastance. And as we can see, that's calculated through trigonometry by the end systolic pressure to P max difference, and we divide that over this stroke volume. So change in pressure for a change in stroke volume, and that's the slope of that line. And the effective arterial elastance is calculated by connecting the end systolic pressure over the stroke volume, and that gives us the slope of the EA line. And because there are common volume terms, and we can cancel them out, and the coupling ratio simplifies to the P max over the end systolic pressure. And the P max can be calculated by methods described back in the early 2000s by extrapolating, doing sine wave extrapolation of this RV pressure curve in early systole and diastole. We can also use a volumetric method where we're no longer calculating this pressure maximum, but we're assuming that the volume in the right ventricle under zero loading conditions is zero. And then we can draw a line from this end systolic point to this theoretical zero, and of course this then cancels just to being end systolic pressure over end systolic volume. And again, EA can be calculated the same way as previous, and because we have common pressure terms, this then cancels out to give us a simplified volumetric assessment of RV-PA coupling. There are obvious limitations to this and a lot of assumptions that are being used in this simplified method. And number one, of course, being that assuming that this volume in the right ventricle is zero under zero loading conditions, and we know that that's not true in patients with pulmonary hypertension especially. And so using this method, we will underestimate coupling. And similarly, if we're using pulmonary artery catheters and assuming that the mean pulmonary artery pressure equals end systolic pressure, then we know that that underestimates that, and we're going to overestimate coupling. And finally, the key question that comes up a lot is, isn't the stroke volume of end systolic volume just telling you the same information as RV ejection fraction? And of course it is in some ways because it's mathematically related, as you can see here. But the relationship between right ventricular ejection fraction and these coupling metrics is non-linear. And the red lines here, and this is in a paper by Rebecca Vanderpoel's group, the red lines signify lines of prognostic importance, so ejection fraction of 35% and coupling metrics of less than 0.5. And you can see this nonlinear relationship in this larger physiological range of the coupling metrics. And so the question then is, could these coupling metrics be more sensitive to detecting earlier RV dysfunction? And this simplified metric has been proven to be prognostic in subsequent studies by Rebecca Vanderpoel's group. So just moving on now, just in the last 4 minutes, sorry, I'm slightly running out of time, the bedside surrogates of coupling. So there's a few different echo metrics that are used to be applied at the bedside. And the TAPSE really is a measure of RV contractility or a surrogate of that, and your pulmonary artery systolic pressure is a surrogate of afterload, and there are other indices that have been described. So this ratio, this simplified ratio of TAPSE to pulmonary artery systolic pressure was validated in 52 pulmonary hypertension patients by Tello in 2019. And what they found was comparing this to single beat methods, which they used a cutoff value for uncoupling of 0.8. They found that at this cutoff value, TAPSE to pulmonary artery systolic pressure emerged as the best discriminator to detect uncoupling, and they found cutoff values of 0.31. They then looked at these cutoff values and found that, in fact, patients with TAPSE pulmonary artery systolic pressure ratios of less than 0.31 is associated with higher mortality. But interestingly, in this study, the ratio didn't particularly correlate too well with invasive single beat methods of coupling. So then this brings to the question of, are these coupling metrics superior to our standard methods? And this paper, this very nice paper in 2021 by Smizer et al. Of 110 patients with heart failure, compared all of these surrogates. And they showed that TAPSE to pulmonary artery systolic pressure has really similar but almost slightly inferior correlation than TAPSE alone, or fractional area change, which is another metric that we use commonly to assess RV function. And certainly the TAPSE to pulmonary artery systolic ratio didn't perform superior to just TAPSE alone in predicting mortality. But it did, I just note they both did perform better than just pulmonary artery systolic pressure alone. So what about data in the critically ill? There are a couple of studies looking at these parameters, one by Zhang and colleagues in 2020 of 180 mechanically ventilated septic shock patients. The overall one-year mortality in this group was 36%, and there was a few exclusion criteria, and all of the patients were mechanically ventilated. And they found by ROC curve analysis this cutoff value, which independently predicted mortality. After multivariate analysis was a cutoff value of 0.5, and the Kaplan-Meier curve shows that patients that had values lower than this had higher mortality at 1 year. And the Dolto study from Quick Care back in 2020 showed that in COVID patients, these parameters also have prognostic significance, with the TAPSE pulmonary artery systolic pressure ratio as well as the PF ratio both emerging as independent predictors of mortality. This is unpublished data. We've recently looked at over 1,000 patients in our unit using the National Echo Database of Australia and using tertiles to categorize these ratios. We can see that those in middle tertiles and lower tertiles with TAPSE, with coupling metrics less than 0.39, certainly seem to have higher short and long-term mortality. Sokios et al. Outlined this nice way that we could maybe phenotype RV injury better at the bedside, and you can see that they included these coupling metrics now, and this TAPSE ratio from the D'Alto study was included at 0.63. So I guess the clinical application of this could be, this is a patient with ARDS who's clinically shocked at day 1 and has these signs with paradoxical septum motion, RV dilatation, so signs of acute cor pulmonale. But the TAPSE in this patient is preserved, in fact, a little higher, but the ratio is quite low, it's 0.5. So does this represent early uncoupling? And I guess the question as clinicians at the bedside is, can we prevent this uncoupling? We can see the TAPSE ratio significantly decreases, in fact halves, the TAPSE goes down a little bit. And can we prevent some of this, this RV failure progression by trending these metrics at the bedside? And are they superior to standard metrics? And I'll just finish in the last 10 seconds, if I may, Professor Pinsky, by saying that these roadmaps have been looked at in chronic pulmonary hypertension by Tello, and they show that as these coupling metrics, that the RV has pretty good reserve until these coupling metrics, which is this line here, drop below about 0.8. And at that point, the ejection fraction, as well as the RV size and dilatation, starts to happen. But we don't really have this blueprint in critically ill patients. And of course, what are the effects of loading conditions and the untrained right ventricle on the pattern of change of coupling metrics in the ICU? And we are starting to look at some of these maybe hybrid techniques to see whether we can start to validate these things a little better. And in summary, I think we know that RVPA coupling is very important prognostically. Future prospective research is needed to establish its diagnostic and therapeutic role over standard parameters. And I think validation studies in the critically ill with these bedside surrogates against invasively derived coupling metrics is very much needed. And I'm sorry to go over again.